My name is Peter Netland. I'm going to moderate this next session, and this next panel discussion is an interesting setup. We're gonna try to get through a few questions that are kind of pre-prepared that have been submitted by patients, families, everybody, and it's important to get to those. We also have to start off with a couple of questions to sort of springboard off the last session, and so we'll start off with a couple of those, and I'm going to invite up my other panelists here because I need you all up here. So Sophie, I'm sorry, but you have to get back up again. Sophie Valleix. And also Jim, I think, is up here. Jim Lauderdale, Neil Lagali, and also Mariya. Moosajee is please come up, and we'll try to field these questions together. Yes. So we have really two tasks. We have to get through a couple of questions first. So I'm going to just ask the panel in general. Can you comment on challenges that you have with genetic diagnosis? We've heard some of those. Also phenotype, genotype assessment, and also comment on potential gene therapies or what you see as the future maybe for gene therapy.
I mean, I would say that Sophie and Dominique have probably one of the largest molecularly characterized aniridia cohorts. And so I think if you pull what's in the literature with what you have, you're going to hopefully get a lot more stronger correlations, I hope. I mentioned missense mutations generally cause milder disease. It's thought that the CTE and the deletions cause more severe disease. But from my experience, I think we just need bigger numbers. And then I'll answer the gene therapy one after Sophie.
Yeah, it's
maybe.
a good point. And I guess I could generalize that question a little bit too and say, well, can you use, we've tried to use visual acuity as a marker of severity of disease, much like many ocular diseases with WAGR versus aniridia. If we could measure PAX6 more accurately, we can do corneal impressions and measure PAX6 levels. That may give us a marker of, if they're really low, that would be maybe more severe than other patients. But we don't really measure PAX6 very accurately now. But any other thoughts about how, and when you do see a genotype that you think corresponds to the phenotype, how good are you at proving that? That's the point.
It depends on the family. If it is a sporadic case or a family with a lot of affected patients, and in this case you can perform genotype-phenotype analysis, but it's very difficult because we observe that for the same genotype in PAX6, the phenotype can vary a lot between affected family members. But this is also true for other genetic diseases. It's like that, and we have no molecular proposition to do. We have no explication.
So this is the challenge of phenotype-genotype correlations. It's difficult sometimes.
Yes.
I would also say that it also depends on which tissue you're considering. So if you're talking about the severity of corneal disease, then you may want some, to do corneal imprinting and look at some of the markers, and you might be able to find it that way. If you're talking about systemic involvement, then we should be thinking about, MRI imaging early on in all of our cohorts and then stratifying that, because I think it could be, again, certain mutations cause propensity towards diabetes. We haven't actually looked at all of those yet, I don't think. So we might start to see more if we correlate those groups with the mutations separately.
Yeah, great point. Any other comments, Jim? Any other thoughts?
One thing that is important to think about in terms of PAX6 is that it actually makes at least 3 different isoforms of protein. And so there's a probability that at least mutations that occur early that affect the paired binding domain are going to have a different set of phenotypes, again, in some cells, than mutations that occur later, because there's a promoter that drives a form that's missing the paired protein, which is still made in patients that have mutations in exons 4, 5, 6.
Yeah, great point. So we can't just measure
I agree.
PAX6 levels from corneal
But
impressions.
it is
and
very
things.
surprising because mutation inside the genes, like PTC or missense variant, result in the same phenotype as non-coding structural variants. Our family have a typical clinical spectrum of congenital aniridia and foveal hyperplasia with severe grade of severe hypoplasia, of foveal hypoplasia. It's difficult to explain the correlation phenotype-genotype, I think.
Well, great. Thank you. Okay, now take a deep breath. We're going to move on to the patient questions. This is a challenge. So let's go through these. We have some pre-submitted questions, and we'll go through those first and try to get through those relatively quickly, so we have time for some open floor questions as well, where anybody can ask any question. So let's go through a couple of the ones that. Thank you, Dr. Lagali, for compiling these. So number one, what is the best way to treat blood vessels growing in the cornea? Are there any studies planned for this condition? And I can start it off with a clinical answer. I answer this question almost every day. We do have a lot of ways to treat blood vessels growing in the cornea. Probably the most common way is to start off with some mild steroids because they have been shown to have some positive effect in reducing the number and the size of blood vessels, so that can be, work. A lot of corneal specialists will start, and there are a lot of other more targeted therapies that are being developed now. Approaches like using mitomycin C injections are very unpopular now, especially in aniridics, because they can cause some collateral damage. But other strategies are becoming popular, and it's related to another question that was asked about insulin eye drops. Are those being used? Insulin eye drops are being used. I have several patients on them, and they're quite comfortable and can be effective a little in reducing the blood vessels a little bit. But there are some better therapies, and Dr. Lagali himself is involved in a study with Cole, looking at that pathway as a possible way to shrink blood vessels, and I think that's a really, really promising approach for the future. Other targeted therapies are coming out. We have VEGF A and B is not generally effective. Inhibitors, there's many of those. They're not very effective for shrinking blood vessels in the cornea, but combined with anti-VEGF V and C and D, that would be possibly very effective, at least according to the literature. So we're looking at VEGF C and D inhibition as a more targeted therapy. Dr. Lagali is also, we're collaborating now, as of yesterday, on some other interesting projects about shrinking blood vessels. But right now, I would say the most common approach is to start off with some mild steroids. But that's a double-edged sword, right? Because then you can have glaucoma problems if you give a lot of that. There's a related question to that I wanted to kind of scan down to. Are there optimal options for controlling the intraocular pressure if the cornea is severely altered by keratopathy? Any answers to that one? Anybody on the panel? Or we were talking about earlier. Cornea one is a tough one, but I get this one a lot too. Yeah, I think so. The idea there is if you do have if you're using mild steroids, and you have severe keratopathy, try to limit them because chronic steroid use in more than, say, 3 or 4 times a day, and 100% of times does lead to an increased intraocular pressure over a period of time, relatively short time, several months. So yes, the optimal option is to try to use pulse therapy of steroids if you need it, or lower doses or milder steroids if they must be used with the keratopathy. And generally speaking, try to avoid them. Otherwise, there are no other restrictions on the other treatments for keratopathy. Okay, have studies been done on epilepsy in relation to congenital aniridia and PAX6 mutations? We're all going to look to Jim on that one.
The short answer is there's no study that I'm aware of that is focused. What we do know is on a very limited number of patients that have seizures, that it's challenging. But it's best to work with an epilepsy specialist to try to control it.
Now, would you say in general, in your experience, have they been, like, there are some pretty severe forms of epilepsy, constantly having seizures, really strong medications, still not controlling it. Would you say that it's generally a milder form of epilepsy with the...
Sorry, yes. So again, very limited sample set, but the patients that I know are on the milder side.
Okay. The next question was, okay, I'm sorry, I'm gonna jump in on this one because this is a glaucoma one. So, can COSOPT be used for a long-term period as a glaucoma treatment for congenital aniridia? The manufacturers do not recommend these drops for long-term use, and I'm going to slightly disagree with that a little bit, and say that the manufacturers don't seem to recommend that. It's recommended for long-term use. However, we have some patients that don't tolerate the medication for long-term use. It's a small percent. It's a fixed combination of timolol and dorzolamide. So the dorzolamide part is the part that causes the corneal symptoms. And it's well known that dorzolamide in about 10% of patients causes a mild superficial punctate keratitis. And so in about 5% of patients, it's necessary to discontinue the drop because of symptomatic mild superficial punctate keratitis. So you can develop a little bit of surface irritation. Sometimes it's enough to cause an individual patient, because patients vary in their tolerance of side effects and have varying efficacy to medications. So as you try the medication, you may find that it's a bit irritating, and so you may have to stop it. And the reason that COSOPT is irritating in general is because it has a very low pH. It's around 5. It's one of the most acidic eye drops that we have because of the dorzolamide part. So an alternative to that drop, if you can't tolerate that but might want to stay on the carbonic anhydrase inhibitor part, is to use a non-fixed combination, use the timolol, and then add to it a carbonic anhydrase inhibitor that's better tolerated because it has a more neutral pH. And that would be brinzolamide. So write that down. If you're the person that asked this question, write down brinzolamide. And then make sure that it's available in your country. In the US, we have it, it's called Azopt. In Europe, it's called something else. But it's available everywhere. So if you have that problem, you can find an alternative medication solution that allows you to use that medication without having that side effect. Okay, so I'm going to keep going real fast here. Some countries, some doctors recommend insulin. Oh, we talked about insulin already. Okay, when a person with aniridia has several conditions, what should the approach be to selecting medication in order to avoid side effects that might negatively affect the eyes? For example, if a patient has asthma, a common treatment is corticosteroids, or let's say sinus congestion, that have a negative impact on glaucoma and cataract. Should an alternative treatment be used? Are there any studies looking into amplifying effects of different medications on the eyes? Yes, many studies, and that is a great point. So yes, if you do have asthma as a coexisting medical condition, or you have sinus congestion or other things that have required or been recommended for steroid therapy of various kinds in the past, it's probably good to seek non-steroid alternatives. And the sinus congestion is a good example. There's like about 20 different classes of medications that are used for sinus congestion. You don't have to use steroids. There's many alternatives. And so I think the main thing is to emphasize to the doctor that, if you need to avoid the steroids because of the low chance, but real chance of systemic absorption and then the potential for increased intraocular pressure, then raise that to your internist, and they will find an alternative in 99% of the times. Otherwise, notify your glaucoma specialist, and we'll look out for the eye pressure. Next question, we only have 2 more questions. Many patients have nodules in the thyroid gland. Are any statistics on this matter in Europe or in the US? And if in my panel, would anybody like to comment? I'm glad to comment on that too. Any comments? Okay, I'm sorry. I get these questions every day, so I can answer this one too. Okay, so thyroid. In medical school, we discovered that certain things, if you live long enough, you'll get them. If you live long enough, you'll get a cataract. If you live long enough, if you're a male, you'll get prostate enlargement. Sorry, Jim. And another one is thyroid disease. Thyroid disease is very common in the population, and so it doesn't surprise me that as some of our patients that have aniridia also have some thyroid condition that develops at some point. When we've looked at that in our group, and we've done some other things that are related to Mariya's talk, and I'd love to comment on those, but we don't really have time today. But I will say that it's really important to compare those to how common are things in the general population. And we did look at thyroid disease, and there were some people that said that they did have thyroid issues, nodules or increased thyroid size or whatever. But that's no higher than the general population. So the general population has that issue too, so we can all share in the joy of getting thyroid issues as we get older. So, and including anorectics. but it's not special to aniridia as far as we can tell. Okay, and then the last question is, artificial tears are widely used in aniridia, and they have different components. And there's a whole bunch of different specific things written down here: panthenol, thiolose, coenzyme Q. If you read the label really carefully, what's in all these things, even in the vehicles, you can really drive yourself crazy because there's a lot of names of things in there that you think could have some activity. So are there any studies to compare the efficacy of different of these elements, components, in treating corneal keratopathy? Are there, because we use artificial tears to start with keratopathy. There are studies on thiolose that compare it to autologous serum and coenzyme Q as a support in controlling intraocular pressure. So any thoughts or comments on that? I'm a glaucoma person, so I hate to take all these questions, but I get this one every day too. Okay, so there have been a lot of studies on artificial tears, and there are small amounts of really strange sounding things in the artificial tears that are chemicals. And they're used for various reasons. And each one has a specific reason for being added in, but when artificial tears exhaustively have been checked, in terms of their effect on intraocular pressure, they don't have an effect on the intraocular pressure that's significant. And it may be that you could take some of these components and determine that there's some sort of effect on the eye pressure, perhaps. But that's been true of every vitamin that's been, that we know of exists, has been also tested individually, and some of them have some mild effects on eye pressure, most don't. But in the doses, they're used in micro amounts in artificial tears, and artificial tears in general have not been found to affect the eye pressure. So we don't really have any concern about that. We do have a concern about sensitivity to some of the components, like you may have a special allergic reaction, or you may have some insensitivity to some of the components, which is true. But in terms of affecting the eye pressure, we don't seem to get much of an effect of that. So I think I'm just going to say that one's probably not too likely. And on that note, I'm going to open it up for general questions before we take our break. Any other thoughts or questions from
I have
anything?
a question. Oh, there's one in the back. Take the one in the back first, or two in the back.
Thanks. So my question is about medication. So our daughter is on has been on COSOP for a while, and this is not just specific to her. It's, I think, applicable to others. And then, pressures increase, she's put on another, and pressures increase, she's put on another. But meanwhile, there is some cornea deterioration. So how do you know whether that's cornea deterioration would have happened regardless of the medication plan versus as a result of maybe long-term use of something like COSOP?
Yeah, that's a great point. And I think there you may have to advocate for your daughter a little bit to say, look, we because it's unclear, right? And you bring up a great point. So in that situation, there may be enough irritation. It is an irritating medication. You may want to raise up the possibility that this could be affecting things. And it's always possible to have a therapeutic trial off the medication, so you can just stop it for a while, see how it goes. There are many alternative glaucoma medications that can be used. So you're not really stuck on that one. You don't have to use it. So I think it's a great question. And generally speaking, I would push a little bit on that one with your physician and say, look, we'd like to try to stop the COSOP and maybe find an alternative to that if we need to. First, you can just stop at least one component, the durzolamide part, and then see what the pressure is. And if it doesn't go up, then maybe you're okay without it. But if it does go up, maybe you might have to find an alternative, and that's okay. What you're looking for also is, do you see an improvement in the corneas, and do you see an improvement? Because I've just mentioned that there is a real thing that can occur to the corneas with a surface irritation that is real. They just have to look for it. So have them maybe start off by looking at the slit lamp with some stain and see if they see the punctate keratopathy. And if so, that would be a physical finding that would as a clinician, would encourage me to find an alternative anyway. You're saying it could be related to the cornea is not doing as well. There's some sensitivity to it, and I say, well, there's the physical finding, so it's real. So, just advocate a little bit. You may have to educate the clinician a little bit, because that is the most common side effect with that particular drug, is that surface irritation that you can see at the slit lamp. So see if you can push on that a little bit and maybe find an alternative, to that medication.
Peter, can I just say something as well?
Yes.
I presume that when you're advising them on these drops, that aniridia patients should always be on preservative-free as well.
Yeah, that's a great point.
So if you're not, even including for lubricants, you guys should be asking for preservative-free lubricants or glaucoma drops. So there are versions of those glaucoma drops preservative-free, which will reduce the irritation
So they
as
are
well.
preservative-free. Follow-up would be, how long of a trial would you do? Because if vision is stable, you don't want to mess anything up by saying, okay, we'll go off of it, and then vision goes down, right?
2 to 4 weeks. It takes a while for it to wash out, and that's a standard amount of time. So you don't have to worry about it in the short term too much, but you don't want to put it off for months to recheck the pressure. So just make sure it's safe, and as you try to come on and off things, medical therapy is frustrating that way because you have to. It's trial and error, right? Efficacy and side effects vary from person to person, so you have to be prepared for a kind of a long road of trying things and then not being able to use them, and then maybe in some cases, and then moving to something else, and until you find that optimal regimen. So it's hard, and that's a great point about the preservative-free as well. So those are good things to look out for, and I think mainly just play an advocate role and make sure that you're not uncomfortable with anything that's going on with the treatment. But those are a couple of things that are standard things that can be done to kind of modify the treatment as you go along. Yeah, and then sorry? Yep.
You talked about that if you have multiple diseases and you use several medication, that it could amplify the sinuses. But I had a doctor that said that using several eye drops didn't affect the rest of the system. But one doctor said that she had considered all my eye medications because it could go in the bloodstream. So I was curious about how much is the small doses, how it affects your bloodstream, because none of my other doctors considers it's never.
That's a really good point, and I did not mention the reverse situation of I mentioned the systemic medications affecting the eye, but it's really a great point because some of the eye drops have been known to cause systemic side effects. So we always make sure, for example, if somebody's on a beta blocker, they don't have asthma, they don't have heart disease and things like that. So yes, systemic absorption does occur. It's relatively low levels, but for some individuals, it's been known to cause some significant side effects. So, I think one of the things you have to be aware of is if you have any particularly pulmonary or cardiac problems, then several of the drops, can affect those things. So it's a great point. It can go the other way around, where when you start an eye drop, the ophthalmologist has to have some awareness of your systemic conditions because some of the eye drops do have systemic side effects. So it's a great point. So before we wrap up, anything else, Ivana? Okay, yeah, definitely.
I could speak without. Okay, 2 questions for you. One, what is your suggest for a country where you don't have a protocol? The doctor, the ophthalmologist doesn't have a protocol for a patient diagnosed with aniridia, which should be the first genetic analysis to do, one. And second, have you ever considered to have a regional view across Europe, for example, for countries like, I don't know, in Eastern Europe, where you don't have that much, don't have a cohort or is a small one, to see the prevalence? For example, I don't know, I'm from Romania, for example. There was a nuclear accident at Chernobyl. Can it have an implication, I don't know, for parents, for grandparents on their children? I don't know, it is only an idea. Thank you.
So the next session, which Dominique is going to be involved in, is to discuss European-wide protocols for managing aniridia patients. So I'll leave that answer for later. But the answer is yes. Gene Vision is a very good source that you can point your local doctors to so they know what to do. So yeah, that's the answer to that. Events like Chernobyl, yes, it could have caused multiple mutations in those affected, and those could be passed down. But equally, patients get sporadic mutations. I say to a patient, we have 3 billion letters in our genetic code. if you ask someone to write that out, it would introduce X number of typos. So we all have about 5 million genetic changes that make us unique. And of that, 10,000 are potentially disease-causing. We don't know where they came from. They could just be occurring in the baby, in the womb, in itself, or passed down from parents. So you're never going to know the answer to where the mutation came from.
Thank you.
Along those lines, we had an in-panel question about, in-panel point that we didn't answer the question about gene therapy. Any thoughts about gene therapy?
So again, you're going to hear from Elizabeth Simpson, I think, tomorrow about gene therapy. I don't think she's here at the moment. But so I think in terms of treating aniridia patients, there's two ways to look at this. There's the management, which is what we've all been discussing. So once you've developed, for example, cataract or glaucoma or keratopathy, these are the things that could be being done. Then there's actually treating the actual genetic mutation. That leads to questions of when is the optimum time to do that, and then what benefit will it have? So if you have someone with end-stage disease, they're really going to fall very much more into the management point, maybe the limbo-epithelial stem cell grafts or corneal transplantation, etc. If you've got young children with PAX6, but still with quite, good clear cornea, no signs of any glaucoma at that point or cataracts, then maybe a genetic therapy at that point would actually have some benefit. But bearing in mind the back of the eye, the fovea, which has not developed properly in utero, you're not going to be able to reverse that. So we've done studies where we've looked at the visual acuity of patients with aniridia, and it's remained pretty stable over 5 decades of life, obviously dependent on whether they get glaucoma or keratopathy, etc. But generally, your vision's stable. So you're not going to get an improvement because that fovea is never going to develop further. So you're not going to get that area of central vision back. But what a genetic therapy may do is reduce, therefore, your chance of glaucoma, keratopathy, cataracts, etc. And they are the things that will reduce an individual's vision further. So then it comes to what genetic therapies. It could be a gene replacement, so actually delivering the PAX6 gene back to the eye. And it could just be the anterior segment that needs to be treated. I don't know if there's any, structural brain anomalies, again, you're not going to change that. Maybe it may help with some adult PAX6 functioning in the other organs, like the pancreas, etc. I'm not sure. But certainly anterior segment delivery of a PAX6 gene therapy would help. Then it could be, for example, delivering the actual gene. It could be delivering the mRNA to the retina. That might, to the front of the eye. That may help. You could even think about CRISPR-Cas9 gene editing, using some form of lipid nanoparticle to apply that to the front of the eye. It may help with some of the limbo-epithelial stem cell populations that are there to correct the PAX6 mutation in vivo, so then it can continue to produce more healthy copies of PAX6. There have been, in the past, you would have heard of the nonsense suppression therapy, which was so that was a small molecule therapy to override a specific type of mutation, a nonsense mutation. That went through a clinical trial. It was unsuccessful. It could be, and this is a good point that I want to mention, the trial endpoints that were being chosen. They used reading speed with both eyes open as one of the primary endpoints, and that was not going to change over a 1-year time point.
I can comment on that as well briefly. I don't want to interrupt you, but yes, they used reading speed, which was not in the beginning of the study as an endpoint, and that was done on a small percentage of the patients. And then they also used visual acuity, so and they didn't look at any other endpoints, and we never saw the data from the data set. So I think it was an unsatisfying end to that because they couldn't get it FDA approved without an improvement of vision.
Yeah.
And the company made their decision on that. So I don't think we really have an answer on treatment of nonsense mutations with that type of approach. For certain things like keratopathy, for example, and other things that that are significant in aniridia. But yes, it was tried, and we can say that at least.
But there are companies that have newer, more effective forms of read-through agents being developed. So it's not because necessarily that's failed, that's not going to work. So there may be more options coming in the future. But on that one note, I would just like to say, although it's great that all of us are putting together the natural history of, 2% have this and 5% have that, what we actually need to start thinking about is prospective deep phenotyping studies on aniridia patients, following them prospectively for at baseline 6 months, 1 year, 2 years, to actually find the parameters that we want to use for clinical trials, which will show a response to treatment within the time frame of a clinical trial. So that's just something that we would need your help with, but something that we all maybe need to think about, because it's great that these therapies are coming, but if we don't have an endpoint that will measure a response, we'll end up with failed trials.
Great point. So on that note, maybe, Jim, any other comments? Did you have a comment about it? On that note, we're way over for the break, so let's take a break. And I want to thank you all for the questions and that you submitted and asked here today. Thank you.